Hi, everybody. Now we're going to start on the topic of the lungs. So, as respiratory therapists, this is very important to you, and this is the the basis of understanding the different types of diseases of the lungs that you may encounter in your career as respiratory therapists. So, we're looking at the lungs and the structures of the lungs here. Um, the lungs will usually weigh 1,000 grams, no, and 450 will be the left lung, and then 550 will be the right lung. Okay. Okay. Oops, nawala. Ano nangyari? Okay. Okay, we're back. Okay. So we're going to start off the lungs. We will be discussing degenerative lung diseases, inflammatory, neoplastic lung diseases, and diseases which will involve the pleura. An overview, we will be reviewing the normal anatomy and histology of the lungs, and then we will proceed with pathologic diseases of the lungs. We will first start with congenital lung diseases, atelectasis, acute pulmonary injury, obstructive versus restrictive lung diseases, and of course COPD, restrictive pulmonary diseases, and vascular pulmonary diseases. And then part 2, we will be discussing infections and neoplasms and the pleura. So this will involve discussions on effusion, pneumothorax, and tumors. So we have part 1 and then part 2. So looking at the lungs here, it is this, there are 2 lobes of the lungs, the right lobe and the right lung and the left lung. Okay. And then these lungs are divided into lobes. The right lung is divided into the upper lobe, the middle lobe, and the lower lobe. There's 3 lobes in the lungs. And for the left lung, you have the upper lobe and the lower lobe. So these lobes will further be divided into segments. Okay. And then usually the right lung will weigh more than the left lung. And then usually the bronchi, as it subdivides, it will be accompanied by your bronchial arteries and then your veins. Okay. And then there's also your visceral pleura, your parietal pleura. So your visceral pleura will be adherent to the lung, and your pleura, the parietal pleura, will be will be closer to your thorax. And then of course, you have your alveoli, no? You have your bronchi, your bronchioles, your terminal bronchioles. You have your alveoli, type 1 pneumocytes, type 2 pneumocytes, your macrophages and your capillaries. Well, here this is a microscopic view. You have your macrophages and capillaries. You have billions of alveoli in your lungs. You have to remember that you have billions of alveoli, and this is involved in your gas exchange. So let's look at the diagram here. So you have your endothelium. Your endothelium. Okay. And then you have your interstitial cells, you have your epithelium, your type 1 epithelium, and then you have your type 2 epithelium. So this is an area where you have exchange of gas and blood in this area. And you have your capillary lumen there present also. So looking at how the lungs are formed. So the lungs start forming at 5 weeks intrauterine. You have your laryngotracheal fold and groove right here. Okay. And then they will develop lung buds. And these lung buds will become your primary bronchi. As you can see, it's already forming into your right and then your left. And then you have your visceral mesoderm, and then you have your esophagus. And as you can see, while you are forming your lung buds intrauterine, there is a close proximity between the esophagus and your trachea. Okay. At the 6th week of life, here you have your trachea is much better formed. You have the right lobes being formed, the right lung, the right bud, okay, has formed and is now developing into your 3 major lobes of your right lung. And so the same is also seen in your left lung. So you have the right lobal bronchi being already formed much better so that it's prepared to go into your lobes of your lung. Here I'm showing you a normal X-ray, a normal adult X-ray, and you can see normally, you know, there is a black appearance of your lungs on the X-ray because it is filled with air. And here you can see that the bones, the structures, will have a whitish appearance, and there's a more opaque appearance when you look at the heart. So kita mo mas maputi siya, and that's because there is the presence of fluid, namely the blood. So the blood will also appear as white. Bone structures will also appear as white, and then air will be a little more dark, which will be that is how air will appear. So here you have your trachea. This is a bit darker. See that? Because of course there is air present in your trachea. And then right behind it will be your esophagus. And then you have your right lung, and then you have your left lung. And then you have your cardiac silhouette here. And then you have your hemidiaphragms. This is your diaphragm, the dome of your diaphragm. Here, if you notice, this is your costophrenic angle, the angle between your lungs and your diaphragm. Anything that will blunt that, later on I will show you x-rays, will denote the presence of fluid. So you have to be familiar with what is normal so that you will know what is basically abnormal when you see it. So now let's go to congenital heart diseases. So you have different different causes of sorry, galing lang tayo sa heart. Okay, so balik tayo. Now let's go to congenital lung diseases. So you have different causes of congenital lung disease. You have agenesis or hypoplasia, where there is failure for the lungs to actually form properly. And then you have tracheal and bronchial anomalies, like the presence of your tracheoesophageal fistula. And this abnormality is usually one of the most common congenital abnormalities with the lungs. And then you may also encounter vascular anomalies, congenital emphysema, and that's usually idiopathic in nature, foregut cysts, pulmonary artery malformations, sequestration, or no connection to the airways and pulmonary arteries. So we're going to be focusing on your TE fistulas, because this is one of the most common congenital malformations for the lungs. So I was mentioning earlier that in utero, starting at the 5th week, you're already forming your lung buds. And as you can see, there is a close relationship with the trachea and the esophagus when it's being formed in utero. So let's look at how the foregut is partitioned. So you have partitioning of the foregut. Okay, you have A, B, and the C. So here you have your respiratory diverticulum, and this is your foregut. And then you have the esophagotracheal septum. And then here you have the pharynx, the trachea, and then the lung buds. Trachea, okay? And then the pharynx is higher. And then you have the development of the esophagus going down below. So as you can see, there is a close relationship between these two. So usually, when it comes to esophageal atresia or your tracheoesophageal atresia, this is the most common form of congenital problems with the lungs and its proximity to the esophagus. Okay. So let's look at this problem first. Okay, your esophageal atresia, which will usually occur 9% of the time. So this means that here, this is your esophagus. Okay, your esophagus. And this is your trachea. Okay. There is a form of atresia, and this is the atresia, the area of atresia, where it did not form properly. And then here you have esophageal atresia. So here, again, a form of esophageal atresia. The esophagus did not form properly. It did not connect with the upper portion of the esophagus. Instead, the upper portion of the esophagus connected with the trachea. So surgically, this will have to be corrected. Okay, here you have correction of the atresia that will be surgically corrected, and this portion, these two lower portions, this will be connected. And then here, you will have to remove the connection here, and then this will be attached to the other portion of the esophagus. Here we have another form of atresia where the upper portion of the esophagus and the lower portion are both connected with the trachea. Most common, you will find that when you feed the babies, they will develop cyanosis. And one of the dangers here is that they will develop as forms of aspiration pneumonia. So, okay, you see this one, and this will probably develop aspiration pneumonia and cyanosis, same as this one. Because when you feed the child, it will go, instead of going to the lower portion of the esophagus, it will go to the trachea and therefore to the lungs. Here, you have another form of atresia, but the upper portion is not connected to the esophagus, to the trachea. The upper portion of the esophagus is not connected to the trachea. It's the lower portion that is connected to the trachea. And this is 82% of the time. And this is the most common form of TE fistula that occurs. Here, you will find that the baby will have a form of failure to thrive and will be spitting out, or there will be there will be sabi natin backflow of milk, no? Meron siyang failure to thrive because any feeding that you give will not go down, it will just go back up. Okay. And then here you have a TE fistula without esophageal atresia. So you have no atresia, the esophagus is formed very well, but there is a connection between the trachea and the esophagus, and this occurs 6% of the time. So there is tracheoesophageal fistula without atresia. Okay, the next topic will be atelectasis. And I think we're out of time, so we will stop for now. Okay. It's already 11:49, and I know you have class next. So we will be tackling the next topic in pulmonary pathology. The next topic will be atelectasis. And I believe you already have the handouts I believe I already gave you the handouts for the entire topic. Okay.